I'm Dr. Asim Javed. I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning process for performing mechanical thrombectomies in acute ischemic stroke. Globally, every fourth person aged over 25 years will suffer a stroke in their lifetime. These are European Cardiovascular Disease Statistics 2017. So that's quite an alarming figure. Natural history of stroke, two-thirds patients will either die or live with moderate to severe disability. Only one-third will be lucky enough to live with minor disability or recover fully. 87% of all strokes are ischemic and 13% are due to bleed. Out of these, 35 to 40% of ischemic strokes are large vessel occlusion strokes. What do we mean by large vessel occlusion or LVO strokes? This means internal carotid artery, middle cerebral artery, or basilar artery. Why these are important? Because these are the ones that have the maximum disability and highest mortality. So LVO stroke, the good thing is that these LVO strokes are now reversible with intervention if treated in time. IV L-teplase or TPA is not very effective as sole treatment in large vessel occlusion stroke. Now this is something very important to remember. If you look at IV L-teplase, US FDA gave approval for stroke intervention of thrombolysis in 1996. But we know that with thrombolytics, we have time constraints, there are so many contraindications, and then most important of all, it is very effective as you go into the smaller and the distal arteries of the brain, but as you come towards the large vessels like internal carotid artery, the effectiveness of thrombolytic is around 4 to 8%. So this is not very effective as a sole treatment for large vessel occlusion strokes. So 2015 trials came out, and then mechanical thrombectomy became class 1A indication for large vessel occlusion stroke. We know that 30 to 40% of stroke patients have comorbid cardiac conditions. Now, I was trying to look for statistics for Pakistan. The exact figures were not there. So what I've done is I've looked at figures from United States and then extrapolated these figures onto Pakistani population of 230 to 240 million population. So according to the US statistics, ischemic large vessel occlusion stroke. So I'm not talking of the whole stroke. This is ischemic large vessel occlusion stroke, which is reversible, needs mechanical thrombectomy. It should be around 31 per 100,000 per year. This is the expectation, and that's the reference for this figure at the bottom of the screen. And now extrapolating it onto Pakistani population, that means we should be looking at around 70,000 to 90,000 large vessel occlusion strokes per year, which need intervention. As per Pakistan Neurology Society, they suggest around 100,000 LVOs exist per year in Pakistan. Now, we know that stroke incidence of Pakistan, as per publications, is around 250 per 100,000 per year. So I have now used this figure to calculate the total stroke, and then 31 per 100,000 per year, the US statistics to calculate the LVO stroke from Pakistan. So if you look at this, total population 240 million, strokes per year is around 600,000 in Pakistan, out of which the large vessel occlusion stroke should be around 77,000. And then I've calculated this for Punjab, Sindh, all provinces, and I've also calculated this accordingly for all the major cities of Pakistan. So Karachi has expected large vessel occlusion stroke of around 5,000 per year, Multan is around 600, Faisalabad 1,000, Lahore is 4,000, Rawalpindi, Islamabad around 1,000 potential candidates for mechanical thrombectomy per year, Peshawar is around 600. So again, the same slides showing the mortality in Pakistan from stroke, the stroke statistics, and 30% of strokes occur at the age of 45 years or less. So we have quite a large number of young people having stroke. Again, I've used these calculations to calculate per day, per year, per month, all of these calculations for Pakistan, for Punjab, and then based on these, what I can tell you is that almost one stroke occurs every minute in Pakistan and nearly one stroke death every 2 to 3 minutes in Pakistan. What are we doing about this? Such a huge burden. What are we doing about it? So currently there are around 200 neurologists in Pakistan, which is less than one neurologist per 1 million population in Pakistan. And what about the number of trained interventional neurologists? You can count them on fingertips. 1, 2, I can't think of a third person. So, according to European Society of Cardiology Council on Stroke, we need at least 2 mechanical thrombectomy centers per million population. So, if you have a population of 240 million, then you need ideally 480 mechanical thrombectomy centers in Pakistan. What has been done so far? So till 2018, there was no mechanical thrombectomy service at all in Pakistan. Rawalpindi Institute of Cardiology started its mechanical thrombectomy service on 13th April 2018 and in 2021 became the first hospital of Pakistan to provide 24/7 mechanical thrombectomy service. So far, till March 2025, these figures are valid that mechanical thrombectomies performed by cardiologists in Rawalpindi Institute of Cardiology was 584. Another thrombolytics were around 367. 10 interventional cardiologists are now independent stroke interventionists in RIC. No money has been charged from the patients. It's all been from the hospital's own budget provided by the government of Punjab. So no patient pays for anything. No cardiologist gets any fee or any incentive, financial incentive for doing thrombectomies at late hours of the night. Non-interventional neurologists and radiologists are part of the stroke service. It is not cardiologists alone doing it. It's the neurology team which does the case selection and the post-procedure care. It's the radiology team which helps with the image interpretation. The interventional cardiologists only play the role of doing mechanical thrombectomy in the cath lab. Dr. Hamid Sharif is one of our interventional cardiologists of Rawalpindi Institute of Cardiology. He is undergoing 2 years neurointervention fellowship with Dr. Adnan Siddiqui and his company in Gates Vascular Institute, Buffalo, New York, United States, and he will be completing his 2 years in August 2025, after which we are hopeful that inshallah he will return to Pakistan and we will request the government to upgrade Rawalpindi Institute of Cardiology into a comprehensive stroke center, and we will request them to allocate further neurology and neurosurgery seats to Rawalpindi Institute of Cardiology with a bit of increase in our infrastructure. What is the West been doing about it? So if you look at this, St. Petersburg experience, so St. Petersburg till 2015, only 25 patients were undergoing mechanical thrombectomy per year. But then the government took the initiative, asked them to provide 24/7 service, which they did not have the numbers to provide. So then government asked interventional cardiology to get involved, and now by 2019, they were performing 650 cases per year with reported successful reperfusion in 81% of cases. Now, I've given a glimpse of a lot of these publications here, which you can go and see on the net. Hungary, Brazil, Turkey, Prague, all of these places, interventional cardiology has been doing stroke intervention. Czech Republic, Germany, Poland, South Africa, then you can see USA. So what's been happening is that countries like USA, they involved interventional cardiology initially. When they had sufficient number of trained neurointerventionists available to them, the cardiology took a back seat on it. But till then, cardiology was used to develop the service. So third world countries need to do the same. They need to involve interventional cardiology because they are everywhere in the country, in every city. You have cath labs, you have interventional cardiology setups there with CT scans. So you just need to add a neurologist to their team. Radiologists are already part of the cardiac centers, so you can very quickly start mechanical thrombectomy service by training the cardiologists, and later on neurointervention can take over. So why interventional cardiology? So stroke intervention parallels to primary PCI for acute STEMI. What does a cardiologist do every day? They remove blood clots from blocked arteries, that too in a moving target because the heart is beating, and in an awake patient. This is exactly what you need for an interventionist to do stroke intervention. And here the target is not moving. The patient may be under cautious sedation or even general anesthesia. So this is the key message from the Inter-Society meeting, European Stroke Organization, European Society of Minimally Invasive Neurological Therapy. So A lot of neuroradiology society, neurosurgery society, neurology society of Europe, and European Society of Cardiology Council on Stroke. This is a combined message that was given in 2018. These are their actual slides which were shown in EuroPCR in Paris. So according to these, training of new interventional neuroradiologists would require more than 2 to 3 years versus training of the experienced interventional cardiologists, which can be done in less than 2 to 3 months. So they did give requirement for a cardiologist to enter stroke intervention training, and they wanted the cardiologist to have at least 3 years of experience in his own interventional cardiology before he could venture into stroke intervention. Now this is World Federation for Interventional Stroke Treatment, WIST. This is their document for give guidelines for interventional cardiology to start doing mechanical thrombectomies. So two important messages that they've given here. One, they feel that according to them, mechanical thrombectomy experience of around 25 cases is required for a cardiologist to get trained in stroke intervention. And this can be done on live cases or even on simulators and 3D flow models or cadaveric models. They are okay with that if the cardiologists get trained on it under proper supervision of trained neurointerventionists. Very important message that they've given here and highlighted here is that if the center is only providing mechanical thrombectomy service, then neurosurgery does not need to be available on site. Only if cerebral coilings and if somebody is dealing with the bleeding aspects of the brain, only then you've got to have neurosurgical backup on site. For mechanical thrombectomy alone, if a cardiac center wants to do it, you don't need to have neurosurgery on site. An MOU or understanding with a neighboring neurosurgical team setup should be sufficient. Now this is a joint paper of European Society of Cardiology Council on Stroke and European Board of Neurointervention, and in that they have said that an experience of 50 mechanical thrombectomies should be sufficient for an interventional cardiologist to get trained. Other requirements are also there of reading CT scans, CT angios, IV thrombolysis, carotids. That's there in this document. Now, carotid and stroke intervention are part of the interventional cardiology curriculum. Now, this is the Bible of interventional cardiology, Topol textbook of interventional cardiology, and you can see that stroke and carotid interventions are very much part of interventional cardiology curriculum. Now, this is the PCR EAPCI textbook which we all read, and here you can see endovascular treatment of acute ischemic stroke has now been included in this book as part of the curriculum for interventional cardiology. So, mechanical thrombectomy for acute, stroke intervention and carotid intervention are now officially part of the CPSP curriculum for FCPS interventional cardiology. Now, to learn the theoretical aspects, there are different courses that go on. ASMINT, European Society of Minimally Invasive Neurological Therapy, they have their own stroke diploma. And then this is the WIST certification to perform acute stroke interventions as an independent operator. They examine you for that also. So a lot of cardiologists are now doing this. A lot of them have already done this. Now this was an MOU, Memorandum of Understanding, that was signed between the President Pakistan Stroke Society. This is a neurology body. So this is Dr. Aisha Zafar, head of neurology, Lady Reading Hospital, Peshawar, signing the document. This was done on 19th January 2024 in Peshawar, according to which Pakistan Stroke Society acknowledged Rawalpindi Institute of Cardiology as a stroke center, and the training program was endorsed by this society. And as part of the agreement, in every training cycle, Rawalpindi Institute of Cardiology would include one neurologist on recommendation of Pakistan Stroke Society. That's the Memorandum of Understanding. Now, a joint meeting was done between National Interventional Cardiology Board, NICB, which is a regulatory body nominated or formed by federal government on instructions of Supreme Court of Pakistan to regulate matters of interventional cardiology in Pakistan. And so it was a joint meeting between NICB and Pakistan Society of Interventional Cardiology, attended by all the appointment holders in both the organizations, and they jointly endorsed acute stroke intervention, that's mechanical thrombectomy, as part of the interventional cardiology procedure. Some of the details, I'm going to just quickly touch on them. They've given a complete document as to what training will be involved, how it needs to be done, where it can be done, and which centers can provide this service. So the eligibility criteria for a cardiologist to perform mechanical thrombectomy includes minimum 3 years of experience as an interventional cardiologist, has full registration of Pakistan Society of Interventional Cardiology, and then he has to complete the training pathway which has been defined in this document. According to this document, he needs to do theoretical knowledge based, something like the XMED course that I've mentioned here, or one of the local courses that are being done. Then 100 cases of brain CT and CT angiograms, 25 cases of IV thrombolysis, 15 cases of cerebral angiography, carotid intervention, 15 cases as second operator in mechanical thrombectomy, and then 15 cases as first operator in mechanical thrombectomy. Prerequisites for cardiology setups to be eligible to provide acute stroke intervention service. They are going to set up, any cardiac center who wants to do this service then has to establish a 24/7 stroke intervention service. They've got to set up a department of stroke neurology or an MOU with nearby neurology facility. Preferably they should have in-house 2 to 3 neurologists, interventional or non-interventional. Minimum 64 slice CT scanner should be available on site, and then in-hospital neurosurgery facility is not mandatory for mechanical thrombectomy services, and then there are other details to this as well. Which centers can give the training? So any cardiac center that performs 100 or more mechanical thrombectomies per year will be eligible to apply as a training center, and then Pakistan Society of Interventional Cardiology will approve the cardiac center which can provide stroke intervention training. Of course, if any other neurology center comes up in the future in Pakistan which is able to provide training, that center will definitely be there. So this is the, based on this, there was a specialized healthcare and medical education Punjab ministerial meeting that took place on the 5th of December 2024. These are the minutes of that meeting, and in this, the Health Minister Punjab, Mr. Khwaja Salman Rafiq, advisor on health to Chief Minister Punjab, the presidents of the different societies of Pakistan Society of Neurology, Pakistan Stroke Society, presidents of Pakistan Society of Neurosurgeons, President Neuroradiology Society of Pakistan, President Pakistan Society of Interventional Cardiology, and many other appointment holders, including the Chief Executive Officer of the Punjab Healthcare Commission and the Secretariat itself. They were all included in this. So it was a multi-speciality meeting that took place, and after long deliberations and turf wars, final decision was that after thorough deliberation, the committee unanimously agreed that while neurologists are the ideal professionals to perform neurointerventions, given the limitations in trained human resources and the high patient load, it would be a prudent decision to allow cardiology hospitals with angiography machines and trained personnel to perform mechanical thrombectomy only, provided a neurologist is present during that. So, in the presence of neurology, a neurologist in the center, mechanical thrombectomy procedure can become part of the cardiac centers. And based on this, then the notification came out which permitted and nominated Rawalpindi Institute of Cardiology to carry on and continue the mechanical thrombectomy service in Rawalpindi. So this is what which we have been suggesting to the government, that you have cath labs all over. For example, I'm just talking about Punjab right now, one of the provinces of Pakistan. So you've got cath labs. All these red dots are the public sector cath labs that are there and being run by cardiology. So Rawalpindi Institute of Cardiology is already performing mechanical thrombectomies. For south of Punjab, there is no service available at all. So Multan Institute of Cardiology could be a potential place where the service, in collaboration with neurology and radiology, they could start the service. In Lahore, Punjab Institute of Neurosciences is available, although it does not perform 24/7 mechanical thrombectomy, but they need to start the service, and the government needs to ensure that the neurologist there convert it into a 24/7 service. And if they can't do it, then there are so many options available within Lahore where cardiology can play the role and start the service. So Government of Sindh is already fully supportive of cardiology to spread stroke intervention service and setting up satellite centers. So till March 2025, cardiologists in Sindh performed mechanical thrombectomies, NICVD Karachi 350, SICVD Tando Muhammad Khan 65, SICVD Sakkar 50. In the private sector, Taba Heart Institute Karachi has already done 10 mechanical thrombectomies. Gambhat Heart Institute of Medical Sciences performed 2. KPK is picking up. Hayatabad Medical Complex Peshawar had done 20, and Peshawar Institute of Cardiology had done 2. So these are all figures where cardiologists have done mechanical thrombectomies. So as of March 2025, cardiologists have performed more than 1,000 mechanical thrombectomies in acute stroke in Pakistan. We now urge the government to include stroke mechanical thrombectomy and carotid intervention on health card. That's the government-sponsored health insurance in Pakistan. Places where cardiology setups cannot run stroke intervention service. Now, this is very important, that if cardiologists don't get the support or there is no provision there with them to perform, to provide 24/7 service, at least cardiologists should learn this intervention to be able to manage their own complications, because we know that during cath procedures, patients can develop stroke. So, just to give you an example, this is primary PCI of right coronary artery being performed with heavy thrombus burden in the RCA that's visible there, and during intervention, patient became unresponsive. We immediately took shots of the cerebral circulation, and you can see left MCA occlusion here, and there's a clot sitting there. So immediate contact aspiration was done, and TK3 flow was established, and patient was rescued. Now this was a live case of transaortic valve implantation going on. This was in Lahore 2023. The procedure went very well. It was smooth. Patient was under general anesthesia, but as the patient was weaned off, they realized that half an hour later, patient was unable to speak and move the right side of the body. We did an angiogram for the patient, a CT angio, and we found that there was an MCM2 occlusion, tip injection, you can see here from the microcatheter, and then combined aspiration and stent retriever technique was used to retrieve the clot, and the patient gained 5/5 power on the cath table. This was a live case during Pakistan's annual interventional cardiology meeting. Another case, 44-year-old gentleman, he had primary PCI to LAD 6 days ago and now presented with 1 hour history of hemiplegia left, and ECG again showed anterior STEMI. So patient was hemodynamically stable, so taken on to the cath table, performed the mechanical thrombectomy first. You can see the occluded right and middle cerebral artery here, and with contact aspiration alone, TK3 flow was established, and then dealt with the anterior STEMI. So no heparin given, continuous saline flush was maintained through the guide catheter, as we've learned in the stroke intervention. And with that, this is the thrombus aspiration with a thrombuster, and then this is the 3.5 millimeter non-compliant balloon, and that's the final result. Agrostat bolus intracoronary, that's half the coronary dose that we give, that was given, and at the end of the intervention, an nasogastric tube was inserted, and ticagrelor 180 mg and disprin 300 mg were given as loading doses to the patient. Now this is a 31-year-old lady, again something we see very often, prosthetic mitral valve, 9 weeks pregnant, came in with 4 hours history of left-sided hemiplegia. Power was 0/5 in the left upper and lower limb, and that's the material that came out with the stent, and TK3 flow was established. And this is maybe only 3 hours post-intervention that the patient is able to move the limbs. Now, this is another lady, 30-year-old lady, peripartum cardiomyopathy, ejection fraction 15%, 3 hours history of left-sided hemiplegia. You can see the blocked right MCA here, and this is with stent retriever, combined technique, TK3 flow established. Another interesting case where, having learned the neurointerventional technique and being familiar with the intervention, with the inventory, it came in handy during cardiac intervention. So this is a 25-year-old boy who was drug addict, was using ice, 3 hours history of chest pain, vital signs were stable, ECG showed anterolateral STEMI. So this 25-year-old was taken onto the cath lab, and you can see the heavy thrombus burden that's there in the left mainstem and the LAD. We decided to leave him on thrombolytic infusion, so we gave him streptokinase. But the patient did not improve, STs did not resolve, chest pain continued, so it was failed thrombolysis. So we took him back for rescue PCI. And you can see thrombus still sitting there in the left mainstem, proximal LAD. There's an occluded distal LAD and distal diagonal as well. So thrombus aspiration was done with Thrombustor. You can see Thrombustor going down all the way. And this is the result after multiple runs of Thrombustor. LMS and proximal LAD thrombus still persists. So we brought in the stent retriever Solitaire X 4 into 40 millimeters. It was deployed through Rebar microcatheter, and we used a 6 French guide liner to use for as a contact aspiration catheter, because the Sophia Plus can only go through, or the React can only go through an 8 French guide catheter, and we had a 6 French guide catheter for the coronary intervention. So we only used the stent retriever to go in and then retrieve everything. So, and this is the final result. Stent retriever worked beautifully in the coronary. So this is the first report of thrombus aspiration with the help of stent retriever in Pakistan. This strategy can prove very useful in patients with heavy thrombus burden such as coronary ectasia, coronary embolus, and patients with late presentations. So the knowledge of neurointervention came handy in the cardiac intervention. Then it's very important that if your cities do not have a proper stroke intervention service, because currently in Pakistan there's hardly 1 or 2 interventional neurologists, and they are not doing 24/7 mechanical thrombectomy. So what about the other cities of Pakistan? So if you are sitting somewhere and you should be able to help your own families, your own colleagues, you must learn this intervention. So this is an interventional cardiologist father who was brought to us with 8 hours history of coma. You can see clot sitting in the distal basilar artery. So we did the intervention and the patient went home walking. This is father of our own catheter, 65-year-old male, 50 minutes history of left-sided hemiplegia, had a very bendy, elongated internal carotid artery. So the length of the equipment was a difficulty to take in. So we had to go for a direct carotid puncture in his case. So you can see here direct carotid puncture with a micropuncture needle. And then after having confirmed that we were at the right place, 6 French sheath was put in. And through that, we did the mechanical thrombectomy and recanalized the MCA. Now, this was a doctor's wife with severe mitral stenosis and atrial fibrillation, 36-year-old lady, 1 hour history of aphasia and right-sided dense hemiplegia. You can see I see a terminus occluded here. The whole brain circulation is missing. And with contact aspiration, huge clot burden was removed and TK3 flow was established. And this is just few hours after thrombectomy that she was able to move limbs, and she's back to complete normal functional life. So a lot of training has been going on in Rawalpindi Institute of Cardiology. We are imparting training to any interventionist from all specialties who wants to learn. So we've been running workshops, conferences since 2018. These are just glimpses of the different conferences that we've been doing. These are some theoretical, audiovisual based conferences, workshops, and then in different hospitals in RIC, we've started doing 3 days hands-on mechanical thrombectomy workshops in which we do live cases and we do live carotid interventions. So a lot of work is being done at Rawalpindi Institute of Cardiology to help cardiologists and other interventionists to start this vital service all over Pakistan. So teamwork is the key to success. Majority of cardiac centers have cath labs and CT scans. With support of neurology and radiology, interventional cardiology can play a vital role by performing mechanical thrombectomies. You must ask yourself a question. If you or your loved one, God forbid, has stroke, do you have this facility in your city, and is it a 24/7